Thank you. Thanks for having me. Let's see. So my job today is to take you through the RSV vaccine clinical trials in adults. So I'll start with just giving you a bit of background on the vaccine and how it was developed in terms of, just the development and the antigen that's used, and then briefly compare the two vaccines initially. After that, I'll just go through the New England Journal studies or the phase 3 trials for each vaccine separately, and just end with some takeaway points and then what's coming soon. So this is really the timeline. So a lot of times this happened even with COVID when the vaccines came through. People just thought they came out of thin air. But in fact, I think we all should appreciate the scientific, time and effort that went into developing these vaccines. So the first thing was really just finding this RSV fusion F protein, which sits on the surface of the virus, and that helps the virus infect human cells. So that was in the 80s. In the 90s, researchers were able to find that it was, in fact, that protein, that F protein, that induced immune response. In the 2000s, there was evidence that there were two forms of this F protein, the pre-fusion form and the post-fusion form. And there were some vaccines that were developed then, and you may have heard about them, which weren't very successful. It was then recognized that it was the pre-fusion F protein that was the most protective. And so it really was in the 2020s where these the vaccines using the pre-fusion F protein form was able to make vaccines that were more protective, and so trials were initiated. And this just shows you, this is the pre-fusion state, and this is the post-fusion state. And some of us might remember there were some RSV vaccines that had been in development, but they weren't successful. Most of them were made out of with antigen using this state, and so really this is the state that is the most immunogenic. And so this, what this antigen does is it mediates viral fusion and host cell entry, and it elicits the most protective antibodies. What you should know as well is that this F protein is highly conserved between both subtypes A and B. So there's two subtypes of RSV that infect humans, and it's both A and B. So even though each one has their own, they're very conserved. And it was really when at the NIH, the scientists were able to stabilize the antigen in this pre-fusion protein state that vaccines could be made successfully. So the two vaccines we have that have been FDA approved just this year in May, the first one is the GSK vaccine called RSV, and it's RSV, the pre-F3 antigen. It's made from the RSV-A strain, but it's adjuvanted. So the difference is it is adjuvanted using their AS01E adjuvant. It's their proprietary adjuvant. It's also used in the Shingrix vaccine, but for this RSV vaccine, it's used in half the dose amount. Both trials were done for both vaccines actually in those age 60 and above, and there are combination trials with flu vaccine as well. So the other vaccine that was approved soon after is the Pfizer vaccine known as Abrysvo. It's a bivalent RSV vaccine, so it uses subtype A and B for the pre-fusion protein. Both of them are recombinant proteins, by the way. And it's not adjuvanted, so that's probably the major difference. Again, both of them have trials with age 60, and then there are some combination studies with flu vaccine. So here, if you look, are just the comparisons in terms of efficacy against what it's not exactly severe, but what they're saying is they're patients who had 3 or more symptoms, so more than just mild. And if you look at season 1 efficacy for GSK, it's 87.5%, and for Pfizer, it's 84.6%. If you look at season 2, and what season 2 meant is that patients went through a whole nother season, but still had that one dose right before season 1. And the overall efficacy between the two is 77.5 for the GSK and 81.0 for Pfizer. Breaking it, this is for each vaccine separately, and this is from the MMWR, which was data presented to the CDC. So here you can see for these numbers you've seen now, and this is for just regular 2 or more symptoms, lower respiratory tract disease. Season 1, the GSK was 82.6% efficacious, and season 2 alone, meaning if you had the vaccine in season 1 and now you got RSV in season 2, was 56.1%. So quite a bit lower, although combined you still have that number of 74.5. For Pfizer's Abrysvo, it's a bit higher. Season 1 for this lower respiratory tract disease, 2 or more symptoms, was 88.9%. Season 2 is 78.6%. So that's season 2 alone after getting the vaccine in season 1. And combined was 84.4%. Safety concerns, one of them that is true for both vaccine is AFib. So AFib within 30 days of vaccine. GSK, there were 10 cases of AFib in the vaccine group and 4 in the placebo. 2 out of the 10 were new onset in the vaccine group and 1 out of 4 in the placebo. For Pfizer's, the numbers were the same in terms of 10 versus 4, but 6 out of 10 were new onset in the vaccine group and 2 out of 4 in the placebo group. So AFib is a somewhat of a concern that FDA has, and they are asking for post-marketing data. The other concern, which we'll talk about when I go through the rest of the slides, is the Guillain-Barré. So other limitations of both studies are they were both underpowered to show benefit in both hospitalization and death. Some of it could have been that these trials were done during, as Dr. Ian had said, during the COVID season. So there was decreased hospitalization and death in general from other respiratory viruses, including RSV. So that could have been some of it. They're also underpowered to demonstrate efficacy in the age 80 and above, which is actually a group we care probably the most about, and in frail elderly. And neither study included immunocompromised patients. And that is, again, where we see a lot of the morbidity and mortality. And again, also not in nursing home patients. So these are big gaps. And the duration of vaccine efficacy beyond 2 RSV seasons is not known at this point. So just going through the phase 3 trials, the first one I'll show you is the GSK trial. This was published February 16th in the New England Journal. And it's an international placebo-controlled phase 3 trial. There were about 12,500 in each group. All of them were, of course, 60 and over. And their primary objective was to look at RSV-related lower respiratory tract disease as diagnosed by RSV PCR. And so here's the baseline characteristics. The average age was 69.5 in both groups, and 44% though were over age 70, but only 8.2% were over age 80. And 7.6% were Asian, and 38% had pre-existing conditions. So here's the first Kaplan-Meier curve, which shows RSV-related lower respiratory tract disease. So this is 2 or more symptoms, and at a median of 6.7 months, there were 40 cases in the placebo group and 7 in the vaccine group. And so the vaccine efficacy was 82.6% and a very fairly good confidence interval. In terms of acute respiratory infection, so this is your basic ARI symptoms, the vaccine efficacy was 71.7%, and there were 95 cases in the placebo group and 27 in the vaccine group. The other things to point out, remember this is the vaccine that's got the antigen for the RSV-A subtype. So when they looked at the vaccine efficacy between A and B subtypes for patients, the efficacy was about the same, 84.6 and 80.9, and for ARIs, again, 72 and 70.6%. Just so you know, during this trial, about 2/3 of the cases were RSV subtype B. So I think we can be assured that it is effective. In terms of efficacy by age subgroup, also similar for those greater than 65 and those greater than 70. Again, 83% versus about 84%. Other trials that are ongoing just to look for is the multiple RSV seasons. I think I've already given you some preliminary data. There is, I don't show it, but they had a subgroup where they got a second dose at the beginning of the second season, and that was found to be less efficacious. And so they're following the group that's, had the first dose, and they're following through multiple seasons as well. And then I think there is an arm that will get another dose after 2 years. There's also the combination trials, which we can talk about if there's time during the questions. So side effects wise, the RSV, the GSK with the adjuvant does have an increased reactogenicity compared to placebo, 3.8% versus 0.9%, but the frequencies of SAEs were the same in both groups. However, there were some concerning SAEs. One group, and this was not in the NEJM paper, it was in an earlier study, showed a patient who had Guillain-Barré-like symptoms 9 days after vaccination. And there was no comparator arm, but it was definitely probably Guillain-Barré. So that's the GSK vaccine. Now I'll just go through the NEJM paper for the Pfizer vaccine, and this was published a bit later, April 20th, and it was also randomized 1-to-1 placebo versus vaccine trial, very similar. However, more patients, 17,000 in each group, and same age groups and comorbidities. They did have some, stable HIV and hepatitis C patients, but no real immunocompromised patients. In terms of breakdown, the ages were similar, 68, and 5.6% of patients were over the age of 80, and 7.8% were Asian. 51% had pre-specified high-risk conditions, some of the ones you just heard about that we know increase the risk of RSV morbidity and mortality. So here's the efficacy data, the Kaplan-Meier. Here's the RSV-associated lower respiratory tract for more than two or more signs or symptoms. The vaccine efficacy, it looks like it's 96, but in fact it's 66.7 here, 33 cases in the placebo and 11 in the vaccine. So that's the overall, and this is the more mild symptoms, whereas for 3 or more symptoms, the efficacy was actually much better. There were 14 cases in the placebo and 2 in the vaccine group, and the efficacy was 85.9%. And this is for the ARI symptoms, also a little not as good, not surprising, 58 in the placebo and 22 in the vaccine arm, and the vaccine efficacy was 62%. This is a little bit similar to what we see with the COVID vaccines, where people still get COVID, but it's milder, and we don't have hospitalization or death here, but with COVID we do. So this is just to show you the typical signs and symptoms reported. So for those who had 2 or more, you can see the distribution, mostly cough and sputum production, some wheezing, shortness of breath, and tachypnea, whereas if it was 3 or more, it was certainly a lot more symptomatic and with more of the wheezing, shortness of breath, and tachypnea that we do see with RSV. In terms of side effects for this vaccine, local reactions occurred 2 to 4 days after injection, and pretty mild, 12 overall in the vaccine group and 7 in the placebo group. And for systemic reactions, it was really exactly the same, 27 and 26 for all systemic symptoms, typical ones like fever, muscle aches, headaches, things like that. So pretty well tolerated. For SAEs, this is another issue. Overall, it was the same, 2.3% in both groups, but there were 3 events that were considered vaccine-related in the Pfizer vaccine group. So one patient had a delayed allergic reaction 7 hours after the injection, but recovered without any real much treatment. The other 2, though, were cases of Guillain-Barré. One was a patient who probably in the end had Miller-Fisher syndrome, which is a Guillain-Barré-like syndrome. This was an elderly female in Japan who did recover fully. The second was a patient from the US, a male patient who had a myocardial infarction that developed 6 days after injection. But the other thing is that he had symptoms which later turned out they diagnosed as Guillain-Barré, which began about 7 days after injection. And this patient also did recover for the most part. So what the FDA review is that this needs to be followed up post-marketing, both the AFib as well as the risk of Guillain-Barré, because it is higher. There also was, of course, frustration that there was lack of efficacy data for nursing home patients and for those who are immunocompromised. So in terms of the takeaway, I think I've shown you that both vaccines are probably quite efficacious and similar, and the FDA also sees them as quite similar in terms of efficacy, but more efficacious in preventing severe RSV disease compared to those who have more mild disease, compared, and even less so with those with acute RSV infection. Not enough data on hospitalization and death, and I think because of this and the cost and the number needed to treat to save a life, the ACIP came out with a recommendation that yes, this is approved for those over 60, but it should be a decision between the patient and the physician as in terms of shared decision making on whether they should take the vaccine or not. And I think we can again discuss that during the question and answer, but basically based on risk factors for that patient, their own risk sort of threshold, and of course the price. There is a possible increased risk of Guillain-Barré and AFib, and this needs to be monitored post-marketing. And again, we don't really have data on the immunocompromised in the nursing home patients, which is really where we need this vaccine to be studied. So coming soon, there is a combination of RSV and flu vaccine trials. Right now, it is approved to be given together along with COVID, so you could give all three patients, you could give all three at the same time, but the studies still need to be published. Also, both Moderna and Johnson & Johnson have adult RSV vaccines in phase 3 trials, so we are waiting for those. I think Moderna's applied for FDA approval already, and there are some studies being planned or starting on immunocompromised patients. Thank you.